of Pharmacy and Pharmaceutical Sciences. Ladies and gentlemen, you are all warmly welcome. We are gathered here. This is the Gardiner Conference Hall at the Great Hall. So in case someone is asking you where we are gathered, this is the Gardiner Conference Hall at KNUST. A few housekeeping rules. Our washrooms are downstairs, just a floor beneath this room. You find it at the left side of the Office of Grants and Research, the OGR. So you may use the washrooms on the ground floor. I would like to introduce a few dignitaries that have joined us. In fact, you are all very honorable, and thank you all for coming, but we would like to acknowledge the presence of some dignitaries among us. In no particular order, I would like to acknowledge the presence of the Vice Dean of the Faculty of Pharmacy and Pharmaceutical Sciences, Professor Eric Boachi-Jesse. Please, Prof. Yes. We also have the Vice Dean of the School of Medical Sciences, who is also our incoming Provost, Professor Stephen Safo. We also have here the Dean of the School of Public Health, Professor Ejay Bafo. Prof, you are welcome. We have the General Secretary of GAFTRAM, Okoje Abibidro Nana Kwejo Obui. We also have here Professor Regina Apia Opon from Noguchi Memorial Institute of Medical Research. Prof, you are warmly welcome. We have here the head of Herbal Medicine Unit at the FDA head office, Mr. Evans Indeyun. Mr. Evans, you are welcome. We also have here the Ashanti Regional FDA head, Mr. Nathaniel Nanakwabna Nkrumah. Yes, sir. Please, you are welcome. There are several heads of department here, and faculty. You are all welcome. I may not be able to mention everyone's name, but you are all welcome. We have also here Professor Mohammed Mutu Chelu. Prof, you are welcome warmly, please. Yes. For some of the dignitaries, we would have time, and then I'm going to introduce them extensively. So we would want to quickly move on. I would like to introduce or call Professor Mrs. Cynthia Amenin Dankwa to introduce the chairman of our conference. Please, let's welcome her with a round of applause.
Good morning to you all. Please permit me just a minute to establish the protocol to make it easier for speakers after me. Representative of the Provost College of Health Sciences, representative of the Dean, Faculty of Pharmacy, ably represented by the Vice Dean, Deans, Directors, and Heads of Departments present, representative of GAFTRAM, representatives from UHAS, representatives of the CEO FDA, Herbal medical practitioners, faculty, students of Herbal Medicine and Faculty of Pharmacy present here. It's an honor to introduce the chairman for this morning's August program. The chairman for today is a close friend of mine. We go as far back as 1997, when we both came to first year in Kwame Nkrumah University of Science and Technology. Professor Stephen Safo is a distinguished alumnus of KNUST, and he's currently a full professor of medicine at the Department of Medicine and the Vice Dean of the School of Medical Sciences and our incoming Provost, College of Health Sciences. He has substantial experience in teaching undergraduate and postgraduate students, research leadership, and management experience, administrative and boardroom experience, and local and international community service for over 2 decades. Professionally, he is consultant physician and neurologist at the Directorate of Medicine at Confanoche Teaching Hospital from 2010 to date. Academically, he holds 2 doctoral degrees, 2 PhDs, in epidemiology and clinical microbiology from Durham University in the UK and Kwame Nkrumah University of Science and Technology, respectively. He's passionate about context-specific research as a way of functioning locally relevant solutions to the eminent health challenges in our society. And the main area of his research focuses on stroke prevention and treatment in resource-limited settings. He has also made significant research contributions in other neurological disorders, including Alzheimer's disease, Parkinson's disease, and the nexus between communicable disease and HIV and other non-communicable diseases. Ladies and gentlemen, please help me welcome Professor Fred Stephen Sappho, our chairman for today. Thank you very much.
All right, good morning. So I would like to stand on the existing protocols to thank you very much for really nominating me to chair this august occasion. 25 years is such a significant milestone, and I want to take this opportunity on behalf of the Provost of the College of Health Sciences, Professor Christian Ajari, to welcome all of you to this 25th anniversary celebration of herbal medicine and the Herbal Medicine Scientific Conference. I wish you all a pleasant and enjoyable and insightful Herbal Medicine Scientific Conference. At the appropriate time, I'll give a speech to launch the program as it is. So thank you very much, and God bless you all. Thank you.
Thank you very much, Prof. Another round of applause for our chairman. Ladies and gentlemen, this is indeed 25 years of bridging ancient wisdom with modern science. And we are not just looking back at 25 years of history, but we are setting the research agenda for the next quarter century. Let us acknowledge all pioneers, faculty, visionaries who made this journey possible with another round of applause, please. Next on the program, I would like to invite the chairperson of the Conference Planning Committee to give us a welcome address. Please let's welcome Professor Isaac Kingsley Amponsa with a round of applause.
Thank you very much. I'm not the chairperson for the Conference Planning Committee. I'm the chairman of the Anniversary Planning Committee. The chairperson is Professor Cynthia Ameni Dankwa. All right. Prof. Chair, with your kind permission, I would like to stand on the existing protocols. And so I continue. Good morning. On behalf of the Anniversary Planning Committee, it is my distinct honor this morning to welcome all of you to the scientific conference convened to celebrate 25 years of the establishment of the Herbal Medicine program at KNUST, at the Faculty of Pharmacy and Pharmaceutical Sciences, the College of Health Sciences. In 2001, the university commenced this 4-year program, the first of its kind in Africa, to train students who acquire competence to practice herbal medicine, to modernize their practice through science and technology. And this morning, I am pleased to say that all of these objectives have been achieved. Thank you. Yet significant work remains. A key barrier to the wider acceptance and integration of herbal medicine continues to be the availability of robust scientific evidence to support the practice. It is for this reason that in commemorating 25 years of herbal medicine education, we chose the theme Herbal Medicine Education and Research is the key to sustainable development. That is in summary. Now, this conference brings together experts and scholars with considerable research experience in herbal medicine and the allied health sciences, carefully selected to illuminate the theme and share some evidence in support of this practice. The abstracts compiled reflect the depth of scholarship being pursued in our field. I extend my sincere gratitude to all presenters and authors whose contributions fill these pages, to the reviewers whose diligence upheld the quality of the scientific program, and to our sponsors, partners, and well-wishers, we say thank you. I'm grateful for the members of the planning committee, the scientific planning committee, for a great job done. It is my earnest hope that in this conference, we will all remain glued to our seat and participate fully and forge partnership so that we can move the frontiers of herbal medicine, education, and research to the next level. Thank you.
Thank you very much, Professor Isaac Kingsley Amponsa. We have here, as I introduced earlier, the Vice Dean, standing in on behalf of the Dean of the Faculty of Pharmacy and Pharmaceutical Sciences. And next on the program, would like to invite him, that's Professor Eric Boachi-Jesse, to give us his address on behalf of the Dean of the Faculty of Pharmacy. Please let's welcome him with a round of applause.
Thank you very much, Madam MC. Prof. Chair, I would also want to plead to allow me to stand on the extensive existing protocol that has been given by my head of department. So, as the MC rightly said, I'm representing the Dean, who will join us later because he has an emergency. Distinguished guests, colleagues, and then friends, it is my greatest pleasure to welcome you to the maiden edition of the Scientific Conference by the Department of Herbal Medicine, Faculty of Pharmacy and Pharmaceutical Sciences, KNUST, a special occasion marking 25 years of dedicated service to the advancement of herbal medicine education and research in Ghana and beyond. We began as a modest undertaking a quarter century ago, has grown into a field now recognized as an integral part of healthcare, and it is fitting that we mark this milestone with a gathering of the very community that has shaped this journey. This year's conference is themed 25 Years of Advancing Herbal Medicine Education and Research, Strengthening Evidence-Based Practice for Global Health and Sustainable Development. Over the past 25 years, herbal medicine has moved steadily from the margins of healthcare discourse towards the center of global communication on accessibility, sustainability, and culturally rooted health solutions. Yet, this progress carries with us a responsibility to ensure that traditional knowledge is matched with rigorous science and that our practices are grounded in evidence and can stand alongside other branches of medicine. This conference brings together practitioners, researchers, educators, and policymakers with a shared commitment to this cause. We are proud to have hosted 60 research showcases and 3 keynote speakers, each bringing valuable perspective on where herbal medicine practice and scholarship stand today. Across the coming days, we will have the opportunity to reflect on the milestone of the past 25 years, examine the current state of research and practice, and chart a path forward for herbal medicine as a discipline that is both deeply rooted in heritage and firmly anchored in evidence. I extend our sincere gratitude to our sponsors and partners for this support in making this landmark conference possible. And I wish every participant a rewarding and memorable experience. Thank you.
Thank you very much, Professor Boache Jesse. We'll be taking a few more addresses. I hope you are listening to all the addresses. You are not quickly wanting to enter into the scientific session. They are saying very, very, very important things to mark this 25th anniversary, and I think we should all pay attention and listen to what they are saying. Next, we are going to take another address, and I think the speaker has already been introduced, and now he will be giving this address on behalf of the chairperson. He has been introduced as the chairperson of the occasion already. So I would like to invite the Vice Dean of the School of Medical Sciences, who is also our incoming provost, Professor Fred Stephen Safo, to give us the address of the provost. Please let's welcome him with a round of applause.
Thank you very much. Good morning once again. I think the protocols have been established. University and its protocols they've been established. So I want to be sure that I'm standing on very firm protocols. But I want to really acknowledge our esteemed guest speakers, keynote address speakers, for taking time to be with us. Good morning, ladies and gentlemen. It is my great pleasure to welcome you to the Herbal Medicine Scientific Conference, organized as part of the 25th anniversary celebration of the Department of Herbal Medicine. On behalf of the Provost of the College of Health Sciences, I extend a warm welcome to all participants and congratulate the department, all its past and present leaders, staff, students, alumni, and partners on establishing and reaching this significant milestone. The theme for the conference, 25 years of advancing herbal medicine education and research, strengthening evidence-based practice for global health and sustainable development, is both timely and important. It calls on us to reflect on the progress made over the past 25 years and renew our commitment to the scientific advancement of herbal medicine. This celebration is particularly meaningful as KNUST also marks its 75th anniversary. 50 years after the establishment of the university, the need was recognized that we should give herbal medicine a formal academic and scientific foundation. This led to the establishment of the Department of Herbal Medicine within the Faculty of Pharmacy and Pharmaceutical Sciences. You'll agree with me that the department's location within the faculty is highly strategic and significant. The faculty provides the multidisciplinary environment and expertise required to study medicinal plants, identify their active ingredients, assess their safety and effectiveness, develop appropriate formulations, and promote responsible clinical use. It brings herbal medicine together with pharmacology, pharmacognosy, pharmaceutical chemistry, pharmaceutics, and pharmacy practice. And this morning, I also learned that they take some lectures from the School of Medical Sciences. So you have the full package. Over the past 25 years, the department has played an important role in training medical herbalists, advancing research, and supporting the professionalization of herbal medicine practice in Ghana. Its work has helped to bridge indigenous knowledge and modern scientific practice. As we move forward, Evidence must remain central to herbal medicine education and practice. Traditional knowledge is valuable, but therapeutic claims must be supported by rigorous research, proper standardization, clinical evaluation, regulation, and continuous monitoring of safety. This responsibility must be guided by the One Health approach, which indeed recognizes the nexus between human, animal, and environmental health. Medicinal plants depend on healthy soils, forests, water systems, and ecosystems. The development of herbal medicine must therefore promote sustainable cultivation, responsible harvesting, biodiversity conservation, and environmental protection. Herbal medicine also has considerable potential to contribute to global health, local pharmaceutical production, and indeed job creation and national development. This morning when I met the Nana Okoji, you said you are saving the... Yes. We had a conversation where we said that as a neurologist, most of my patients, stroke, epilepsy, they go to the herbal doctors for treatment. And then sometimes when I'm treating them, they are not happy with me, they go there. Sometimes when they are not happy with you too, they come to me. So, so there's a nexus and a connection in there. So there's really an opportunity for job development, collaboration, and national development. And we believe that this potential can only be truly realized through stronger collaboration among universities, traditional practitioners, regulators, health institutions, industry, and local institutions. As we celebrate this Jubilee, Silver Jubilee, I encourage the department to look confidently towards the next 25 years, years that must be characterized by stronger research, innovation, sustainable use of medicinal resources, responsible commercialization, and greater international visibility. I'm not a prophet, but I see the next 25 years, you becoming a school on your own, so that you can really have a defined curriculum and place to train the next generation of herbal practitioners. And I'm indeed confident that the discussions and presentations at this conference will generate valuable insights, partnerships, and recommendations for the continued development of herbal medicine in Ghana and beyond. Once again, I warmly welcome you all and congratulate the Department of Herbal Medicine on 25 years of distinguished service. I wish you a productive and successful conference. Thank you very much, and God richly bless you. Thank you.
Thank you very much, Prof. Safo. Please, let's thank Prof. Safo with another round of applause. Indeed, herbal medicine has prospects not only for sustainable health care, but as we heard from Prof, also in the agriculture sector, even in environmental protection, and also in the economy of our country. Thank you very much, Prof. We are looking forward to transforming Africa's biodiversity into global health solutions. Next on our program, ladies and gentlemen, we'll be taking our keynote address, and it is my distinct honor to introduce our keynote speaker. Please let me say a few words about her, and then I will call her to the podium. Our keynote speaker is a professor of toxicology at the Noguchi Memorial Institute of Medical Research, which is at the College of Health Sciences, University of Ghana, where she has worked for the past 33 years. She is the immediate past head of the Department of Clinical Pathology at Noguchi from 2013 to 2022, where she also supervised the National Newborn Screening Laboratory for Sickle Cell Disease and the Diagnostic Laboratory of the Noguchi Memorial Institute for Medical Research. She's a part-time lecturer at the Department of Biochemistry, Cell and Molecular Biology at the University of Ghana, School of Basic and Applied Sciences. She is also an adjunct professor at the University of Health and Allied Sciences, Hull. Our keynote speaker is a fellow of the Ghana Academy of Arts and Sciences. She is currently an associate editor-in-chief of the Health Sciences Investigations Journal of the College of Health Sciences, University of Ghana. She is also a member of the Non-Communicable Diseases Africa Center for Excellence at the University of Ghana, and a member of the Ministry of Health Technical Working Group to review the monographs on medicinal plants in Ghana. She is a board member and mentor of the Africa Research Academy for Women in Science, where she trains brilliant young ladies from various universities in Ghana in her area of research. Her research interests include toxicology and pharmacology, with a focus on drug discovery, particularly the development of anti-cancer and anti-malarial agents from plant sources. Her work on anti-cancer and anti-malarial activities of medicinal plants has established the anti-cancer and anti-malarial properties of several medicinal plants used by traditional medicine practitioners to treat cancer and malaria. She was part of a research team that adopted the tetrazolium-based calorimetric assay for high-throughput testing of anti-malarial agents. She made significant contributions to the design and construction of a DNA cassette vector that facilitated drug susceptibility testing HIV against antiretroviral agents. From 2009 to 2011, she undertook postdoctoral training for some months each year at the Department of Pharmacology at the Yale University School of Medicine, where she researched the chemical and biological fingerprinting of selected Ghanaian medicinal plants. She has published over 100 articles in peer-reviewed journals, and she has 5 book chapters in her field of study. Ladies and gentlemen, with a standing ovation and a round of applause, let us welcome Professor Regina Appiah-Oppong for our keynote address. Thank you very much. Please take your seats. Good morning, everyone. I am humbled and delighted to be here with you and to be doing something that I'm very passionate about. Professor Chair, I am also going to stand on all the protocols. I hope the protocols don't break as we stand on them. I'll stand on the existing protocols. And thank you all again. Thank you, organizers, for your thoughtfulness and for bringing me here. I've lived in KNUS in my life. I was telling Prof that I lived most of my life, early years here. And so anything that brings me here is very pleasant. Thank you. So the topic for today, unfortunately, I was asking for how many minutes, what time I had, and I didn't get it very quickly. And so you realize that I will have to either rush, and then the MC will have to stop me at a point that my time is up, because I have quite a number of things that I wanted to share. But I cannot go through it all because of the time. I just looked and I saw that everything is important, so I'll cut it at a point. I'm going to try to go through it as quickly as possible. The topic is harnessing Africa's medicinal plants for health and economic development. Please, okay, let me do the changing myself. Yes. Good, sorry. I forgot that I had a pointer. Now I had to change it. It's a bit sticky, not moving. Okay, so that will be the content of my presentation. And this presentation is focused on 3 of the areas of the sustainable development goals, or the
the World Health Organization. So the first one is goal 3, which says that good health and well-being. Good health and well-being. And then goal 8, this is decent work and economic growth. And then goal 9, this is industry, innovation, and infrastructure. I don't know how I'm going to stand, but I need to see the screen and make sure that you are watching my screen. I should calm down. Then I need my papers, right? That's also a challenge. So I'm going to do that.
Anytime you want to control the slide, point forward, not on the slide.
Oh, I should point forward. It will work. Okay. Okay. I'm going to miss my papers because I have very little time and I have to be quick. Okay. Thank you very much. I accept all the suggestions, but let's move on very quickly because my time is running. Okay. So. Yes, herbal medicine. Herbal medicine is a fundamental component of traditional systems of medicine worldwide. Okay, and plant-based medicines represent the oldest form of healthcare and have been used across cultures for thousands of years. So in Ghana, herbal medicine forms an integral part of the national cultures, the nation's culture's heritage, reflecting indigenous knowledge and healing practices passed down through generations. So plant medicines are used to promote health and to diagnose, prevent, and treat physical, mental, and social health conditions. These medicines play a vital role in Ghana's healthcare system, with approximately 80% of our rural community relying on them for healthcare needs. So notably, nearly 40% of modern pharmaceutical products, including several landmark drugs, have been developed from plant sources. And are all of these safe? Are all these medicines safe? Are they, the therapeutic doses, have they been well established? Can plant medicines produce beneficial or harmful effects, interactions when they are taken together with conventional medications? Do we know that? Plant medicines are often assumed to be inherently safe because they have been taken for several years. So we say, oh, it's safe. My grandfather was taking it in our home. We drink every, and so on. But do we have a scientific basis for that? And are we sure about that? So safety remains one of the major concerns that we've heard this morning associated with plant medicines. And that's why we are gathered here. It's part of why we are gathered here. And we are not nailing it, but we are looking at how we can improve it. And so safety is a major concern. Our first president, Osajifo, Dr. Kwame Nkrumah's government recognized and appreciated efforts to promote this area, plant medicines, herbal medicine, traditional healers, and so on. So Ghana Psychic and Traditional Healers Association was established in 1961. And that was a great thing Osajifo did. And then institutions such as the Center for Plant Medicine Research were established to look at research into plant medicines. And they have been working up until now. We thank God for that. Again, there have been other institutions like the Traditional and Alternative Medicine Directorate, TAMD, of the Ministry of Health. The Food and Drugs Authority has also been working with us in this area, Traditional Medicine Practice Council, and then also the GAFTRAM, the Ghana Federation of Traditional Medicine Practitioners Association. The Ghana Association of Medical Herbalists have also kicked in, and then we have some instruments like the Ghana Herbal Pharmacopoeia, and then, as was said, the monograph for medicinal plants of Ghana, which is now being revised. Currently, 55 hospitals in Ghana are piloting integrative medicine under the Ghana Health Service and Ministry of Health. And this is interesting. In fact, the first time I read it, I was making a presentation, I said 35. And I went to a media station and in fact, the interviewer reminded me, Madam, you've gone up to 55. I said, yes, you're right. Okay, so plant medicine industry is among the fastest growing sectors globally. And according to WHO, several developed countries are now buying into it, accepting it and integrating it into their healthcare system. We started, but we seem to be still a bit behind some of them, as you will see. So I'll quickly discuss some research that has been done in this area, particularly things that I have been involved, studies I have been involved in very quickly. I'll start off with malaria, which remains a major problem disease in this country. The parasite is transmitted to humans through the bites of the Anopheles, female Anopheles mosquito. It's a major public health concern in sub-Saharan Africa, affecting mostly children and pregnant women, and that's a major problem for us. Early diagnosis is helpful, and then treatment to prevent the disease. And then also looking at the vector. In our institution, for instance, there are people working really mainly on the vector, seeing what can be done to work at that, and that is key. So the first study or case I would like to discuss is a study that we did looking at a product known as AM1, high adorator. Now, patients, this was a work we did in collaboration with the Council for Scientific and Herbal Medicine, herbal practitioners, and industry research at TESHI. Unfortunately, the lead passed, but it's called AM1. And AM1, we had 5 patients from this facility. We housed them at the University of Ghana Hospital, and 5 of them ages 8 to 24 years. The body temperature, 36.1 to 39. And these were infected, 4 of them were infected with P. falciparum and 1 with P. malariae. And they were treated, observed, monitored, and so on. We did parasite clearance, biochemical and hematological activities where parameters were also assessed. And so for the clinical, if you look here, for the clinical studies, as I said, treatment and then parasite count and monitoring. We did testing to see, sometimes people have taken other medications, so we took the urine sample to see whether they had taken any anti-malarial before we went on to do all the other things I spoke on. We also did preclinical studies on AM1, subacute and acute toxicity studies using rats. We did cytochrome P450 activation studies, and then we did the biochemical assays still on these animals. Okay, so these are the plants that were used. So we have 4 of them. The practitioner tells me, the wife is still around, and we are still working with her, actually, on this product. And she tells me that people try to come and steal the product, but they are not able, because the way they prepare it, you can know the name of the plant, but getting to prepare it is another thing. So we have Jatropha, we have Carcass gossipum, his Hersitum, and then Physalis, Angulates, and then Delonis regium. So these are the 4. Put them together. You boil one, use a filtrate, ferment it, and use it and so on and so on. So that is how it was prepared. So these are the results that we had. If you look here with me, for the very first chart, the A, okay, you see that these are for the days. On the y-axis, we have the density, parasite density. On the x-axis, we have the days. And so you see that for the 4, at the other end is for P. malariae, and the first one is for P. falciparum. And so you see that initially, they were treated, and for one of them, parasitemia went very high to numerous. What do you think? It means that the parasites were sequestering, and the AM1 was able to bring them out from wherever they were, and then started flushing them out. How many drugs do we have that do that? And then flush them out. So by day 9, everything was out of that was the day 7, everything was out for that first person, that person. And then the others came out by day 5, they had all recovered, and they were out of danger. Okay. And so what are we saying? So we're saying that the product has indeed, we have proven that it has anti-malarial activity. We did it in vivo, in vitro as well, and we also confirmed that in vitro activity was there existing. We did not have, for the safety, we didn't have any adverse effects, human and the rats and the animals. We didn't have any challenges at all, kidney, liver function, and so on, glucose, everything was fine for safety. No adverse hematologic, the hemoglobin levels, everything, white blood cells, everything, body weights, kidney, the organs were all okay. But we had a problem with the cytochrome P450. These are drug metabolizing enzymes. There was some alteration, and so the issue there is that we need to do further, tests, because we are a number of SIPs, and they have to do it with certain drugs. So it's important to look further at that to see which SIPs activates, induce, are inhibited by this product. So that has to be looked at. So AM1 is effective in the treatment of P. falciparum and malaria as well. And the potential for drug interactions has to be looked at. Further clinical trials, these are just five patients. So you cannot call it a full-scale clinical trial. And that clinical trials are some of the gaps that we have in herbal medicine. We need to do the clinical trials and do them properly so people can believe us and come along. Okay. So the next one I want to look at is cancer. Okay. So research on cancer, what is cancer? I believe we all can listen. But for us to be on the same page, it is a disease in which some the parts of the body overgrow and they will not stop growing. So it keeps growing and growing. So take that as a so we have, unlike normal cells that will stop growing, okay, these can form lumps and then they continue and spread to other parts of the body. And usually the name of the cancer is coming from where it's originated. Okay. Okay. So there are many risk factors. Sometimes it's interesting. You may see a medical doctor, somebody who is so knowledgeable, and he's so enjoying the risk factors. It's habits, can't come out of it. It's very worrying. You have alcohol, we know, right? We have tobacco. We have excess body weight. We have genetics that mama gave you, daddy gave you. You can't do anything about that one. Sunshine, yes, you can limit it. You can watch what you do, radiations and so on. Unhealthy foods now for us, which we can do something about, right? Our contemporaries and others are very good. Age, nothing you can do. The ones you can't do anything about, that's fine. But the ones you can do something about, let's do something about them. So now I'm going to the next study, looking at Albizia zigia. The accounts call it Okuru. Albizia zigia, Okuru. We've looked at the this plant to see its anti-cancer properties. We focused on that. So it's found in West Africa. It's used to manage tumors, depressions, sleep problems, sore throat, anxiety, asthma, boils, malaria, and so on, and parasitic infections. Okay. So in Ghana, it's purported indeed to have anti-cancer activity, but no scientific research had been done, so we decided to look at that. So major challenges associated with treatment of cancer have to do with resistance, we have to do with toxicity, and the costs also can be really high that you have to sell off your property to finish that, to do that, and you are not sure. And so we investigated the anti-leukemic, anti-prostate, and anti-breast cancer activities of Albizia zeegia. So this is what we found. And so for some who may not be in the area, let me explain that when we determine activity, the lower the activity or IC50 value, the more potent the agent is. It means that very little of it is able to do the job, okay? And when the activity goes high, very high, hundreds and so on, we say that it is weak, it's not doing anything, okay? So we are looking at cytotoxicity because we are looking at cells. We use immortalized cells to do the work. And so we had, for Albizia zeegia, it is important to work with what the herbalists are using. Aqueous extracts, what's being used. So we prepared aqueous extract. And we also prepared the hydroethanolic extract as well to see whether alcohol is drawing anything else, and which will be interesting. We use curcumin as a positive control. And this is what we found. For the aqueous extract, we had very strong activities for leukemia, the blood cancer, 3.09. And in both, you see that in both the aqueous and ethanolic, it wasn't much in leukemia, for leukemia. Very, very interesting. And if you go to prostate also, for the aqueous, you had some moderate activity. But for the hydroethanolic, that was very strong. Okay. And if you look at what we have in the parentheses, that is the selectivity index. So selectivity index, again, you calculate it from the safety, the effect on normal cells, okay, divided by the activity that you found. So if the activity is very low, is very potent, it means the safety margin goes bigger. And then the effect on normal cells is high. It's not doing anything to normal cells. It's relatively safe. And usually from 2, it should be greater than 2. So we'll see what we have in parentheses here. We have 104 there. We have 83. So it tells you something. For even compared with the positive control. And then for the prostate cancer as well, you see that it all shows interesting activities. But you realize that for breast cancer, no. Breast cancer, it was very weak. The activity was not interesting with breast cancer. Okay. So what we're saying is that, indeed, Albizia zeegia demonstrated interesting anti-cancer activity towards the leukemia Jacquard cells and then the link-up prostate cancer cells. Now, but like we said, the breast cancer activity, that was very low. We also looked at, it's important also to look at the mechanism. How does it work? So we looked at some mechanism. Typically, one interesting mechanism is apoptosis. Apoptosis is programmed cell death. So the drug is able to program the cell to die. And that is very interesting and very important in drug discovery for cancer. And so we found that the hydroethanolic one was also able to cause apoptosis. So these have been published. If you read the publication, you get a lot more detail. So these findings provide scientific support for the traditional use of Albizia zeegia as an anti-tumor medicinal plant. Further studies are underway to identify the active, bioactive phytochemical and also determine the mechanism by which these act. Because of the time, I'm tempted to jump over this one. So probably I will jump this one and go to the next one. Oops. Okay. Yeah, I'm getting help there. That's great. Okay. So I have leishmania. Okay. I wanted to look at the one before the leishmaniasis. Yeah. Yes. Very good. So this has to do with trypanosomiasis. Okay. So we did some work in collaboration with our partners in Japan. You know, the Japanese established Noguchi, and they are always supporting us. They have always been there for us. So we did this work with the Japanese and also with CENTER, the Center for Plant Medicine. We work very closely with CENTER. And so the human African trypanosomiasis hat, known as a sleeping sickness, is a major health challenge in many African countries, with thousands of new cases every year. In Africa, 2 species have been found there, the T. brucei gambiense and the T. brucei rhodesiense. Okay. So the gambiense is responsible for 98%, so you can imagine why we are going after it. Just like the P. falciparum, 90%, so we go after that one. So that's the one that we're going after. So therapies, there are some therapies, but of course there are always side effects and all of these things. So there's always a need to find newer agents. And so what we did was that we, as a group, we collected so many plants and we screened them. We try to isolate compounds from this. Of course, as you start, you want to test them to see whether they are active or not in the extract, and then you go on to do isolation of compounds. So that is exactly what we did. The extract, and we went on to do isolation of compounds. We decided to test the extracts, the compounds also on malaria. And so we are saying that, yes, these have interesting activities, and therefore we should use them for other infections as well. Okay. So the next one has to be the anti-leishmaniasis activities, okay, of the same compounds that I talked about. Yes, indeed. If you look at the stages of the leishmaniasis, it's characterized by fever, by headache, by itches, and joint pain 1 to 3 weeks after a bite, okay, of the fly. And a few weeks to a month subsequently, the second stage continues. We have confusion, we have poor coordination, we have numbness, we have difficulty in sleeping, okay, and the diagnosis and detection is in the blood and the lymph nodes as well. And so we looked at the Can we go on to the results sheets because of the time? Okay. So if you look at the results again, here, you see that for the activity, the antileishmanial activities also, you see that 2 of the compounds are showing interesting activities. These are quite low, and for that reason, these are recommended as compounds that will be interesting and druggable, drug candidates. The other compound, ML23, didn't show any good activity at all. And then if you look into the brackets, you see the selectivity. So it's also based on the selectivity that you push the compound. So the ones that the selectivity is poor, you would definitely want to drop it, or you want to do some more work on it. Yes, if the selectivity is not good, you don't easily put it away. You want to find out with the chemistry. That's where chemistry will come in. Why is this so? Can something be done to ensure that it also gets more active? So we're saying that both mollucidin and ML52 induce changes in morphology of the leishmanial parasites, okay? And that, so these are promising compounds, and the other, of course, not. And we are looking at doing and moving it also further. The next what I'd like us to look at has to do with safety, drug interactions, cytochrome P450 drug interactions. So modulation by medicinal plants. And so what we did was that we worked with 3 herbal centers. We collected 3 drugs from these herbal centers. We collected anti-HIV, anti-malaria, and anti-tuberculosis drugs, medicines from 3 herbal centers in Ghana. And thanks to them, they just gave them to us for free. So I give them credit. Okay. So what are cytochrome P450s anyway? So cytochrome P450s are drug metabolizing enzymes. Enzymes, for those who are non-scientists, enzyme is something that is inside a substance that is inside us that is able to break down, okay, substances, okay. And so these are drug metabolizing substances. You take them in, and then these enzymes will break them down into various forms that the body can use, or so that body doesn't like foreign substances. So anything that goes into the body wants to get rid of it. So that's the plan. The plan is I break it down so you can get rid of it. So usually they make substances more water soluble. When it's more water soluble, it's easy to go out. But there's another class, the phase 2, that we lot more water soluble for it to leave. So that is one class of the compound, and it's a very important class of compounds, enzymes that the body needs, okay? And so these enzymes, they have also impact on the drugs that we take, how they impact them. I was just communicating with somebody who sat by me in the plane, and I was discussing cytochrome P450 with them, and I was saying that in Finland, they do not have cytochrome P450 2D6. They know it's Ghana, we don't know what we don't have, but they know. So because of that, if there's a drug coming into their country, they need to know which CYPs mainly metabolize it. If a major CYP is CYP2D6, then they don't want your drug, okay? Because it could cause anything, you know. If they are slow metabolizers, we say they don't have, but it means they're very slow. So if it has a narrow therapeutic window, you are in trouble taking that product. And so we have to do that for ourselves, okay? And so that is why this area, I actually have another project looking at Ghana, who has what, and so on and so on. But for this particular one, we took the herbal medicines from the herbal medicine practitioners, and we selected 4 important drug metabolizing enzymes. Importance by their prominence. So for instance, CYP3A4 metabolizes almost half of the drugs on the market, especially antihypertensives and so on. So CYP3A4 was one of them. 2D6, we have 1A2 also. 2D6, like I said, metabolism about 20 to 50, 30% was one of them. 2C9 causes adverse drug reactions. And so you want to really to have that in. So we did that as well. So because of the time, I'll quickly look at the results. Yes. So these are the results. And if you look with me, okay, so here the first one, the A, is CYP1A1, 1A2. Now, on the X-axis horizontally are the drugs that we got from the, I told you that there were 3 companies, so we had 3 drugs from each of them. So you see 9 of them there, okay? So there are the drugs. The first panel is anti-malarials. The next one, the anti-diabetic, tubercular, and then the next one, anti-HIV, and the next one, anti-tuberculosis drugs. The first bar is the control. So anything below the first bar with asterisks means that it is a very strong inhibitor of the enzyme. If it's above the first bar and it has asterisks, it is likely to induce or activate the enzyme. Okay. So if you look at 1A2, you see quite a number of them. 1, 2, 3, 4, 5 of them are bringing the activity, enzyme activity down, and that is significant. If you look at 2B6, you see that most of them are rather increasing their activity. So they are likely to be what? Inducers, okay, or activators. And so it means then that if you continue to take that product for a long time, you can still hit whatever the impact that would be. And if you come to CYP2C9, which has to do with adverse drug reactions, you realize that all of the drugs that were tested were inhibiting CYP2C9. What does that tell us? And then you go to CYP2D6, 2D6 that has to do with, also 2D6 is very important because it also has to do with polymorphism. There are various forms of it. As we are in this room, we don't even know the forms, how many forms that we have in this room. There are various forms, and all of these impact on functionality. Okay, so it makes 2D6 very important. And so here we have 2D6. In 2D6, you see that it's not too much happening there, but there are some, or no inhibition, but some going up. So it gives you an idea that it has. But the 2C9 is really critical. So we want to say that it's very important, administering herbal medicines and conventional medicines, it is very important that we do some of these things. Last time I suggested this somewhere on a platform, somebody says it's too advanced, and I said it is not. It's killing our people. We need to find out very quickly. Students can do this. I have a lot of students who have been doing this routinely, and so it's not too far for us. We need to know what we take, which drugs can it. There are certain things that are beneficial when we are looking at integrating this. There are certain things that are beneficial when you co-administer. Which ones are not? If we do this, we can say that this product, whatever you take, it doesn't do anything. It will still work. Okay, so it's good for us to identify those ones. So data on co-administration of herbal medicines and conventional is sparse. And we need that for pharmacovigilance. We need to do that. Thank you very much. Because of the safety issues, we need to do that. So that is what I have to say on that. Now let's look briefly at the integration of herbal medicine into primary healthcare system, which is very key. Integration of herbal medicine. Why should we do this? Why integrate herbal medicine into primary healthcare system? Because it improves access. It improves access to healthcare. It enhances also universal health coverage. It promotes patient safety and quality. And then it stimulates economic growth. I'll be talking more on that, I think, tomorrow. And today I'll see if there's time, I'll say a bit on that. And then it supports research and innovation also. So if we say that it improves access, we already know that 70 to 80% of Ghanaians use herbal medicines for some aspects of their healthcare. You cannot stop them. So doing this is a very good way of ensuring that we have, as we've been hearing from the beginning, the rigor, the research that is going and backing it, so that we know that this product, we have been taking it for a long time, doesn't mean that it's safe. You know, we did some research on a product called Calgutine, and people said, it's good when you are going to give birth, you take it and it eases. But the work we did showed that it causes abortion, okay? And if you didn't do that research, you will go with them and say that it is good. Because you will have, some would not have it, but the number of people that had it, the animals that had it, so it means that further work has to be done. Some human people taking it have had abortions, and they try to have some reasons, usually as it's always been, find some reasons for it. But we have to do the research and ensure that our people, our populace are safe, and we owe them that in this space. Universal health coverage, yes, the SDG goals 3, we have our part to play to keep our community safe, to promote safety, as I said, and so on. Economic growth, yes. We create opportunities for work and for all, so that galamsey can go down and our young men will not be dying in pits, but they will get a lot of money. They won't need the pits. They won't need the pits, which is, it doesn't tell you whether you die today or tomorrow, and your life is cut short. So the key message there is that integrating herbal medicines into Ghana's primary healthcare system strengthens the healthcare delivery while promoting economic development, scientific innovation, and sustainable use of the country's rich medicinal plant resources. We have rich medicinal plant resources, and we have not harnessed them as yet. But we have hurdles, don't we? And this morning we have talked about some of the hurdles. We have hurdles. Many countries, herbal medicine is not subjected to the same rigors, the same regulations or standards as pharmaceutical drugs, and that's a challenge. So problems associated with the use of traditional herbal medicines can arise from the classification of these as foods or food supplements. And so it's unfortunate. You don't want to go through the rigorous thing, and so you send the product, you know that this is an anti-cancer agent, but you go to FDA and you say, this is a food supplement, just so that you can avoid that. That is not the way we should do it. So scientific validation is, again, as we have heard, is a gap. Lack of robust clinical studies limits the acceptance of herbal medicines by mainstream medical practitioners. Yes, they want to see the evidence. Does it work? Does it not work? What else does it do? You know, you need to be able to say. I recall that when we had Ebola, a herbal medicine practitioner that I've been working with came to me and said, I have this product, I know it's good for Ebola. And I said, what did you just say? He said, it's good for Ebola. I said, how do you know that it's good for Ebola? Do you know what it will take me as a scientist to test for that? I could even lose my life. Yes, because in growing the virus, you are so exposed, but you just have your thoughts and your faith to go that it is good. That's all you have. You have nothing else. That's all. You know, it's not enough. So we need to do the science and not stick our necks out. We need to be very careful and sensitive and so on, and gradually go slowly. We will get there. Safety concerns, again, herbs have a wide range of undesirable drug adverse reactions, including serious injuries, life-threatening conditions, and even death. Therefore, thorough toxicity assessment of plant medicines is necessary. Some products may cause side effects, yes, contraindications, and so on. And I will not complete that statement by saying that herbal medicine, plant medicine, conventional medicines do not do anything. They have what they do as well. So people also die taking conventional medicines. So we look at the balance. It's just that we need to do the research to support what we do. Otherwise, even if it's coming from here, we'll push it on the herbal medicine. So, for instance, the studies have shown that the liver and kidney functions of medicinal plant users in southeastern Nigeria were found to have problems. Prominently, they're taking these, and it was causing toxicity. So I have a kidney specialist, you know, who he doesn't want to hear about herbal medicine at all. He thinks that is what is bringing his patients to the hospital, you know, and that's quite unfortunate. I think that we have to do the research, and we have to, because when they come to him, they would take the thing before they come. So he feels that it worsens the situation before they bring it there. Can we prove to the medical practitioners that we are helping, or if it is not helping, can we stop them so that they can immediately go and take the one that has been proven to be working? Okay. So misidentification of medicinal plants and mislabeling of herbal medicines may also be responsible for some of the adverse effects that we are seeing. You see a plant, you think that it's okay. I was teaching some students, and I was telling them that young students who saw a product they studied was very good, it could keep them high. Little did they know that it was going to give them a Parkinson-like disease. Okay, so misidentification of all of these things. Herbal medicines are perceived as neutral, risk-free. We have established that already. It may not be so. So lack of funding lack of funding for the production of herbal medicines associated with the practitioners. So sometimes when I have practitioners, I just want to do things for them for free, because the money that you are going to ask him for, he probably hasn't even seen it before, because you are going to order so many things, and he hasn't seen that kind of money before. And how sure is he that after you have done all that, he's going to recoup that one as well? And so funding is a major problem that the government must come in to support. There must be labs where people can send their products to and have them tested, and then government would derive something from it if it is good. And I think we have to do that. Even if it is not good, you have saved your people, because you can say that this is not good and therefore please drop it. Okay. So lack of education of practitioners. Some have money. We went to a conference, some call themselves billionaires. That's fine. But not all of them are billionaires. Okay. And so we need to educate herbal medicine practitioners. We need to support them as much as possible. If they can afford it, fine. But if they cannot afford it, can we still help them? Okay. So about 50% of the herbal products now at Mampong, and 615 products analyzed in 2021, half of them fell below the standard, which is a problem, isn't it? Yes. And so we really, it raises, so when it's like that, people read, we don't want this, because it's just 50%. But we don't just throw away everything like that. We need to interrogate and see how best we can handle this. So another quality issue that compromises safety and integrity of medicines is adulteration of the products. Sometimes we have adulteration. So recently when COVID broke out, they brought some samples. Usually we'll run it to the HPLC to see, and you see that people have put all kinds of things in there, which is bad. Herbal medicine practitioners should not do that. Just keep to your herbs. We don't do that. Please don't add anything to it. The lack of standard operating procedures, and that was also lacking. The procedure must be standard. The way you prepare it must be standard. It shouldn't change. When you harvest it, all these things must be standard. It mustn't change. And also there's a risk of extinction of medicinal plants. It's a major challenge. The chairman mentioned that in his address. Factors associated with extinction include overexploitation, indiscriminate collection, uncontrolled deforestation, habitat destruction, galamsey. All of these are a problem. If you harvest, in fact, there must be, I believe there's a policy, but I haven't seen it, that whatever you must plant. You also have a responsibility to put back. So there's a threshold below which we cannot get our plants back again. We don't want to get there with our very good plants. So a bit on the economic value, and then I land. So the overall economic value of medicinal plants or herbal medicines cannot be discounted. Major source of income and livelihood, employing millions of people in developed and industrialized, or developing and developed, or let's call that industrialized is better, industrialized countries. They contribute significantly to GDP, the gross domestic products globally. The largest markets are China, as you all know, France, Germany, Italy, Japan, Spain, Britain, and United States. Did you see a Ghana in there? Ghana, we started long ago, but we are still not listed there. Okay. So this is data that I found, and on the use of herbal medicines. I saw US now coming up. Australia also, as you can see. We have Chile. We have Colombia. Colombia has been like that for a while. And then all of Africa, they bunched us together out there. Interest in the use of botanicals is increasing in industrialized nations. Japan is the world's largest consumer of natural medicines per capita. So WHO estimates that by 2050, the trade will move to 5 trillion. 5 trillion. Where will we be? Where will we be? And it is also projected, the projected compound annual growth rate. If you look here, you see South America, that is 68 billion, okay? And then they are looking at, by 2032, almost tripling, okay, more than doubling, not tripling, but more than doubling Europe also more than doubling, looking at that. Asia also moving. The rest of the world, we are hiding somewhere in there, even if we can't even be seeing a little bit. You know, that's there. And so on. And so we are saying that we want to see ourselves on the map. When I started doing this for my inaugural, I had opportunity. I went to the Ghana Statistical Service. I said, I want data. I want data. I want to see Ghana. Where are we? What have we done? All they gave to me had to do with many things. Plant medicine, herbal medicine was nowhere at all. Couldn't list it at all. I know something is going on, but it's so minimal that it's not even listed at all. And so what we are saying is that the Ghana herbal medicine industry is a main source of employment in the country. Please move on to the next slide because of the time. I think it's the next slide. The Ghana herbal medicine, industry is a main source of employment in the country. Is a main source, as a large number of people are involved in the value chain of the industry. And about 951 tons of crude herbal medicines, estimated at a total of 7.8 million US dollars, were traded in 2010. So I was looking for something close to, so where are we now? And that was a figure that I could not get. So at the Ghana traditional herbal medicine week celebration, the president of GAFTRAM, that's the CEO of COA, said that the industry could be worth about 76 billion US dollars with concerted. I like that he added with concerted effort. So that is the one that we need to bring the money in. We need that money to kick in because we are rich and we are poor. The green gold, where is it? Where have we reached in harnessing it? Where have we reached in harnessing it? And it takes a concerted from students, from everybody. I hope that all these conferences, the things that we are going to talk about, will encourage you to move on as an entrepreneur, as to move on and see what you can do. You and your colleagues can come together to do what we can do, what I can also do to change the scenario, to make it better. Efforts have been made to develop plant medicines in Ghana. Research has proven that several of these herbal medicines are efficacious, they are safe. Some of them have been done properly, and they can be marketed. And that is why we are putting some of them in the clinics. I only hope that everything in the clinic has been thoroughly looked at. Yes, researchers require funds from the government and other stakeholders to support the work on medicinal plants for significant economic impact. Other challenges associated with the industry could be surmounted if we could be more disciplined and we have the right policies. We really need the right policies to move on. So for significant economic impact, streams of funding must be invested in herbal medicine by the stakeholders, as I said. There are many people who have money, but they don't want to pump it in. And we want to challenge them that this is a very viable industry where money is required, and you will reap it. You will be blessed if you do that. You know, when you are investing, it can be very painful, but eventually we will reap it. You already see signs that herbal medicine is really good. Look at the other countries, what they are doing, and we will get there. To avoid harmful herbal drug interactions, as I said, the potential for co-admission should be checked. We need to check all the products that we have to see whether they have a potential for that. Pharmacovigilance is very important. Don't have much data on pharmacovigilance for herbal medicines. No, I have not seen much of that. Traditional medicine practitioners and researchers must be educated on patent filing. I don't know how many traditional medicine practitioners have filed any patent together. Of course, you need a researcher to do that. And so you cannot hide and say, don't want anybody to know anything about my product. You continue to hold it and die with it poor because you don't want your thing to be, you don't want to be helped. But if you want to be helped, you can get a lot more, okay, from what you have. And you file the patent. We also in research have been a bit slow. Even what we have found, we haven't filed. We have filed just 1 or 2 Okay. And the work I did, for instance, with Yale University, we filed a provisional patent. I got to Ghana, and getting the money to continue has not been that easy. But trusting God that we'll proceed, we'll go on. To avoid extinction of medicinal plants, yes, I talked about, we have to stop a lot of the things. Government must lead the effort for the promotion and cultivation of medicinal plants facing extinction and have a policy to replace harvested medicinal plants. All hands must be on deck. Policymakers, regulatory bodies, traditional research institutions, other stakeholders, you and I, for significant revenue generation for Ghana to develop, to get the worth of the gold that we have, the green gold that we have. We must work together. It is possible. I want to thank you very much for your attention.
Thank you so much, Prof. Let's do it again for Prof as she takes her seat. Thank you very much, Professor Apia-Opong, for that fascinating presentation. We have all learned some biology, pharmacognosy, phytochemistry, pharmacology this morning, and it's truly inspiring to see how nature, and specifically our own medicinal plants, are opening up new frontiers for treating diseases that affect us, like malaria, leishmaniasis, trypanosomiasis, and even cancers. This gives us an incredible hope when it comes to medicinal plants. And as she said, it will take our concerted efforts. Let's not be too quick. Let's do the science. And not be too quick to say that Sobolo can cure Ebola. Otherwise, by the time we finish the research, we'll be finished on this continent. Yeah, thank you so much. Another round of applause. Thank you, Professor. A few announcements, please. If you have a poster presentation, kindly, and you have not put it up on your board, kindly check the last page of the brochure. You will get to see your board number, and then you may take a few minutes to go and put up your poster, because we would have two more speakers, and then we'll dive into the scientific session. We will have our first guest speaker to give us his talk, and I would like to read a bit about him before I invite him. His name is Professor Mohammed Mutuchelo, a professor of biology at the School of Medical Sciences, College of Health Science, KNUST. Professor Mohammed Mutuchelo is a distinguished clinical microbiologist and Fulbright visiting scholar whose career spans more than 25 years of excellence in teaching, research, consultancy, and mentorship. He serves in the Department of Clinical Microbiology at the School of Medical Sciences, KNUST, where he has risen through the ranks from a medical laboratory technologist to professor and an immediate past head of department. He is a fellow of the Allied Health Professional Council, the American Society of Microbiology, the Institute of Biomedical Science, and the Ghana Immunology Society. Professor Mutuchelo is widely recognized for his scientific leadership and impactful scholarship. As a Fulbright visiting scholar at Weill Cornell Medical College, Professor Mutuchelo conducted pioneering research on Cryptolepis sanguinolenta, Ghana's well-known herbal antimalarial medicine, and his work at Cornell advanced and consolidated a growing body of evidence on Cryptolepis and its antiviral potency. These contributions have positioned him as a leading scientific voice at the interface of traditional medicine, molecular virology, and translational research. He believes that Ghana can position itself to tap into the $260 billion global herbal medicine market if that becomes a priority. Professor Mutuchelo has published over 80 scientific papers in high impact journals as well as book chapters. His ability to attract over $800,000 in grants and resources underscores his exceptional scholarly influence, industry engagement, and organizational leadership. Ladies and gentlemen, let us welcome Professor Mohamed Mutuchelo with a round of applause.
Okay, thank you very much. I will also seek for permission and then stand on existing protocols. So, when I heard that Professor Regina Apiopong was going to speak before me last night, I had to change my slides. I had to reduce a bit. We both serve as, we are faculty members in the West African Center for Cell Biology of Infectious Disease at the University of Ghana, so I know her very well. And then we do collaborate a lot, and then our work overlap. So I didn't want to repeat certain things that I knew she would be talking about. So a lot of the basic sciences and other things have been taken away. So I'll focus, maybe to be short, so I'll be talking about transforming local herbal knowledge into global health solutions. Please, I think I can stand somewhere. Yes, so it's going to be short. I'll be looking at Cryptolepis sanguinolenta, which I have established, or our team has established this as an antiviral agent. It's here, and I'm sure a lot of people have seen it. The other one is what we call ECAT. It has an interesting story behind it. Cryptolepis sanguinolenta is known as Ghanaian quinine here, and that is the plant. It is widely grown in southern Ghana and other African countries, usually West African countries. It is, as the previous speaker said, well, she didn't mention it, but she mentioned anti-malarial agents. It is one of them. It's been used to treat malaria for a millennia. And that is how the plant looked like. So just a background. Herbal medicine is entrenched deeply in this country, in our country's health system. And from the previous speaker's figures, an estimated 80% of us rely on herbal medicine for our primary healthcare needs. Its integration is one of the most advanced, featuring specialist herbalists working side by side with orthodox medical practitioners. A typical example is Kumasi South Hospital. There are some challenges. Many of these herbal medicines in the open market lack rigorous clinical trials. If that is so, it means they lack scientific evidence. And probably that is why we are here discussing science and herbal medicine. I have seen from Professor Apiopong's figures. The figures are thrown around. So what I came across was that the market side, if you think herbal medicine is not a priority, then you have to think about it again. The market size as of 2023 was over $70 billion. And it is estimated to reach above $300 billion in 4 years' time. Question is, what are we doing if we think we are poor? Consumers are increasingly seeking plant-based solutions. And it's simple. The synthetic drugs are toxic. Ghana's herbal medicine sector has spent 25 years, we've seen the documentary here, advancing education, research, and clinical practice. This is something I'm very proud of, and I'm sure most of us are proud of that. Yet, deeper pharmaceutical potential of indigenous medicinal plants remain unexploited. A huge task for us. So back to my original topic. So, C. sanguinolenta, this is how the plant is, and it is normally extracted from the roots and from dry versions of the roots and bottled here by the Center for Plant Medicine Research. Research emanating from our lab has shown that it has anti-hepatitis B properties, herpes simplex. These are viruses because of my background as a virologist. And recently, SARS-CoV-2, that's COVID-19. How did it start? Because I'm not from the fraternity of pharmacy or herbal medicine. I'm from somewhere else, but I popped in there accidentally. So 2012, I was back from UK with my PhD, and I wanted to, my background actually is cancer biology, cancer sciences, cancer genetics, because I attended School of Cancer Sciences. I was working on aflatoxin, but then I had challenges, so I wanted something indigenous. So I went there to see one Professor Wood. I was just looking for a herbal compound that would have anti-inflammatory properties to work on promyelocytic leukemia, childhood cancer. That was it. He then directed me to this gentleman I call KB Mensah, who gave me the compound and wished me good luck. I went to my lab, and then we gave it to my PhD student, we started playing around with it. Accidentally, we realized that cryptolipin, which is the bioactive compound or alkaloid of Cryptolepis sanguinolenta, it is activating antiviral defense system in mouse macrophages. I said, what? And I said, yes. I said, repeat the test. We did it 5 times. And that was the beginning of our story. The antiviral defense, interferons, as most of us are aware, are antiviral proteins. They are cytokines. And most of us are aware that over 80% of people, when they get infected with viruses, they clear them, thanks to this pathway. I don't know how you can play the movie because of the broad knowledge base of the people sitting here, but normally interferon, the system, when it senses virus, interferon alpha engages the receptor that then activates a cascade of signaling events culminating in the production of antiviral proteins that defends the infected cell and neighboring cells. And that's why most of us don't die of viral infections, just a few of us. Now let's play we assume this is, let's say COVID-19, SARS-CoV-2, or hepatitis B, whatever. Usually they would have to engage their cells on cell surfaces. That is the cell. And then it takes the virus. That's how they infect cells. Viruses only survive when there are cells. So please play it, but cut it midway. So it engages, it's taken up. Hold on. Now it's entered into the cell. It's going to be sensed by intracellular sensors. They say, oh, we are invaded. Then they communicate amongst each other to trigger the antiviral pathway, culminating in the production of antiviral proteins that disintegrate or destroy this virus and then, protect. Please go ahead and play it. Oh. Okay, play it throughout. Gets in, sense, produce antiviral proteins, OAS, there are over 200 of them. They then, if you see this ring around it, they then protect the virus, and these are the virus waiting to enter. They can no longer enter. And because they've released a lot of antiviral proteins, they then protect other, cells that are not invaded yet. So that's what happens for most of us. And this mechanism, we realized that cryptolipin does that. Then we decided to understand the molecular mechanism. We are scientists. We need to show evidence. So our first paper came out. We showed that the pathway has two arms. We showed that cryptolipin doesn't intervene here. It intervenes in the second arms to trigger the antiviral pathway. So that was published in this good journal. Having understood the molecular mechanism, we wanted an infected person, somebody with a viral infection. So luckily, somebody in the team, the clinical team, knew someone else who had seen a doctor and was prescribed, usually for hepatitis, the person was having hepatitis, chronic hepatitis B. And usually there are two types of medicine, the directly acting antivirals, lamivudine, tenofovir, and so on. He wasn't prescribed that. For some reason, he was prescribed the interferon-based ones, which was 15,000 Ghana cedis at the time. So the gentleman consented to the study, and then with the clinical team, we started. At baseline, his hepatitis B viral load was approaching 1 million copies per mil. 3 months into therapy, it reduced to 24,000 copies per mil. A clinical team, examined, so whilst he was taking, of course, protection, liver function tests were done, clinical assessment, and other hematological indices were all done. They were fine. So the clinical team said, you go ahead. 6 months' time, it reduced to below 2,000 copies per mil. So the clinical team said, well, you don't need to go over it any longer. And that was the publication that we had. We also went on through other studies to confirm that indeed cryptolipin has anti-inflammatory effect. That was the other paper there. So we went further to indeed show that, confirm, because it was already known. So we went through another means to confirm that cryptolipin inhibits hepatocellular carcinoma group through inhibiting this signaling pathway. Then Joy News saw the papers published. They got interested. Can we hear it? To play for about 3 minutes, so please bear with me. Just 3 minutes.
Individuals with chronic hepatitis B infection are at risk of liver disease and a type of liver cancer known as hepatocellular carcinoma. Fortunately, hepatitis B screening, vaccination, and treatment
So this is this is online. This is available. And after this documentary, the number of calls that we get is unbelievable. As far as Palestine, people find my number to call. It tells you how people are suffering and how people want herbal medicine. Please, can we move to the next slide? Yes, so around this time, then COVID-19 started. And then WHO said, well, we should provide people, countries should look for homegrown solutions. And then this gentleman who has seen our data, Professor Evans Adai, I call him Evans, didn't understand why we are sitting on this data. We have to find solutions. People are dying and we are not doing anything. After persistence, then we decided to form a team led by Professor Ellis Usudabo. So it was intradiscipline, and inter-institutions. So we had people from pharmacy, School of Medical Sciences, chemistry, KCCR, Kumasi Sub Hospital, Konfanojo Teaching Hospital, and so on. It was a bigger group. And later on, Center for Plant Medicine, the manufacturers, they joined later on. So we started. But usually you don't get ethical clearance, you need ethical clearance from the FDA to do clinical trials. But luckily we had so much data, scientific. I'm drumming home the importance of scientific data. If we want to tap in the $200 billion, we were armed with a lot of data. FDA was rigorous under that circumstance, where we wanted emergency approval. Series of Zoom meetings, bring this, bring that, bring this, bring that. Yet we survived. We went through. So we went on to do the trial. We got approval from the FDA, which turned out to be the first ever approval for herbal medicine for COVID-19 clinical trial. And I think it's still on their records. We got approval from the Ghana Health Ethics Committee and then institutional approval as well. It took us 2 years, so by the time we finished the trial, the COVID had died down, but we have been able to show that indeed, and if you look at the caption, a cryptolipid sanguinolenta-based preparation reduced hospital stay and mortality of COVID-19 patients during the pandemic. So pandemic is gone, but we have recorded this. Next time it strikes, we know that we have evidence. So some years later, I think a year or so later, I went to Cornell Medicine as a visiting scholar. There I worked extra, but this is a bit confidential. It's meant for a meeting in 3 months' time in Washington, D.C. So I won't go into details, but just to tell you the importance of herbal medicine. So scientific evidence from NUS and our collaborators suggests that it's now changed to Mebima, but we used to call it Nebima. It's an antiviral agent. In fact, it's a broad-spectrum antimicrobial agent. In the next few slides, I'll talk of another drug. We call it ECAT. It's a powerful painkiller, according to the lady who sells it around. She sells it around. I'm sure she's been in your offices. She claims it improves conditions of many people with sciatic pain and osteoarthritis. Tall people like me, usually we have knee issues. And I'm a victim. this is how it is. No label, no name, nothing. Okay. Painkillers, because I'm talking about this. First point is known to all of us. Everyone else here, I'm sure, have taken painkillers. Opioids remains the largest drug class segment, but demand for non-opioids and other OTC alternatives are rising due to what we discussed earlier, addiction and toxicity and cost and so on. And because of that, growing number of consumers prefer natural. Even today, I think there are toothpaste that they are charcoal. The big pharma are moving towards what is in demand. They are moving towards natural products. So what are we doing? Is the question. Now, let me go back to this story. One of our professors, one of our own, had a condition, osteoarthritis. He was preparing for surgery at the time. I think that it was going to cost him 95,000 Ghana cedis, and so on. He could barely move, and the rest. So his friend, they met somewhere else. His friend gave him this 6 pellets of this, and he went home, placed it on the table, and the wife saw it. The wife was saying, Professor Pan. Adi. David. But the gentleman was in pain. And you know, if you are in pain, you will do anything. He started taking it. And then on the 3rd day, he realized a change. So let's call him Professor G, not Xi Jinping, but G. A 55-year-old man who had knee osteoarthritis with comorbidity, hypertension. In fact, the legs were swollen like elephantiasis. It was terrible. He was barely mobile at the time he was introduced to ICAD. He had previously been on conventional medications. I heard a chair talking to another person about how patients shuttle between him and a herbal practitioner. He was on 2 antihypertensives, 2 directives without improvement until he was introduced to I don't know, we know the manufacturer, but I have no share in this. I'm just telling you a story, so I'm not advertising anything. It's not even allowed in this. So the story continues. When he took it, the 3rd day he saw improvement and he continued. And because we know him, we realize that his well-being had improved. And then the team again, led by this gentleman, again thinks we should do something. That COVID is dead, so now let's do something. So Reverend Professor Chasansa had to lead this team to work on this. I also heard Professor Regina, I always affectionately call her Regina, talk about cost, and that the herbal manufacturers normally don't like it when scientists are going to collaborate with them because of cost. We decided to bear the cost ourselves. So, Reverend Professor, I call him Reverend Prof. His team worked on rodents, so pain and inflammation in rodents. Yes. I had to go to Food Research Institute to extract the active ingredient from this, to come and use mouse macrophages, where the inflammatory pathway will be activated in macrophages using E. coli, and then I would measure. When you activate it, you measure. Another person also worked on using HPLC to do, it's not here. There was a 3rd work. And this comes from Reverend Professor Ansah's work. And as you can read from above, which is shown here, he showed a profound anti-inflammatory activity from this. It has no name. Similar to diclofenac. So that's the first data you are seeing here. So the blue bar represents mice that were controlled. They didn't take the drug. And this, as you note, for mice who had increasing concentrations of the drug, there is a dose response curve there. This is ICAT. We called it ICAT because we had to give it a name, and that's the initials of the researcher or the professor who first took it. And the 1122 is November 2022 that he started taking it, and he's taking it up till today. Is that he's reduced the dosage. And you can see ICAD. ICAD is having similar, activity as diclofenac. Before I met this, anytime I was going to travel, I have to take diclo for 3 days before the journey because I have osteoarthritis myself. So this is coming from my lab. Reverend's lab, they did the mouse model. We did the tissue culture version. First, we had to establish the cytotoxicity assay, which we did very well. We had to activate the pro-inflammatory pathway, NF-kappa B pathway in the cells, which is this. And then these are control cells activated, the pathway is activated. And these cells, they had increasing amount of ICAT. So you can also see that at the molecular level, we've been able to show, and this is a lab that is far away from Reverend Professor Ancha's lab. These are far apart. We're getting something similar. And then we quickly wrote it. There was an upcoming herbal medicine conference, national conference, organized by the Center for Plant Medicine Research and other partners. So it's published in there. So ICAD, thanks to Reverend Prof, thank you very much. ICAD has been processed and then it's been submitted to FDA for registration. So this is my last slide. I said it was going to be short. Ghana's our strength, competitive advantage, local herbal knowledge, traditional medicine, biodiversity, the plants are there. But there should be connections. There should be partnership with academia, scientists. We already talked to the FDA and other regulators, standardization, validations, and so on. Then the product, was sold for 30 Ghana cedis at the time. I don't know now. But after registration, it's going to go up. Naturally, it's going to go up. So it becomes globally competitive. And then you are ready to tap into the $200 billion industry. And then we become rich. Thank you very much.
Indeed, we shall become rich. Let us put our hands together again for Professor Mohammed Mutuchela. Prof, that was a very fascinating story about your research journey. Congratulations. Science is indeed interesting. And one thing I learned about his talk is that, when you're doing research and sometimes you are stuck. Like he said, he was working with aflatoxins. And when he returned, he realized that costs and the fungi probably is not available. Then you should look to doing something else, something that's indigenous, that will also benefit the community. So he looked on to anti-inflammatory. And then another thing is sometimes you start with a focus, but you end up with something else. So usually when you're writing a thesis, my professor, Ibrahim Yeboah Mensah, will say the introduction is usually the last thing you write and your abstract. Because maybe you are thinking that, I'm doing antimicrobial, and then your result will say, now the thing is anti-inflammatory, so you have to change your introduction and everything. All right, so, and again, if you want to do far-reaching research that has far-reaching impact, you need interdisciplinary collaborators, industry partners, and so on. So, shall we put our hands together again for Professor Mohammed Motuchela? Thank you very much, Prof. We'll take our last talk, and then we'll move into the parallel oral presentations and then the poster presentations very soon. Let me say a bit about our final speaker. His name is Dr. Andrews Williams Tete. He's the Chief Medical Herbalist and Head of the Herbal Medicine Unit at the Kumasi South Hospital. Dr. Tete is a distinguished academic medical herbalist and public health practitioner with over 16 years of experience in herbal medicine practice and more than 6 years of experience in health promotion. He currently serves as the Chief Medical Herbalist and Head of the Herbal Medicine Unit at the Kumasi South Hospital under the Ghana Health Service, where he also supports the Health Promotion Unit of the Public Health Department. Dr. Tete has made significant contributions to the integration of herbal medicine into Ghana's healthcare system. He serves as the focal person for traditional medicine at the Ashanti Regional Health Directorate and is a member of the governing board of the Traditional Medicine Practice Council, TMPC. He also serves on the Ministry of Health Committee responsible for reviewing and implementing the Essential Herbal Medicine List and is an active member of the Ghana Association of Medical Herbalists. In academia, he is a part-time lecturer at the Department of Herbal Medicine, KNUSC, where he teaches undergraduate students, supervises research, and contributes to curriculum development. His area of expertise include clinical herbal medicine, public health, health promotion, clinical research, health education, disease prevention, and healthcare quality improvement. Driven by a passion for excellence in healthcare delivery, research, teaching, and policy development, Dr. Andrews William Tete continues to champion the safe, effective, and evidence-based integration of herbal medicine into Ghana's health system. Please let's welcome Dr. Andrews Williams Tete.
Thank you very much. The pointer. Thank you very much, Prof. Chair. I crave your indulgence to stand on the existing protocols. Thank you. Medical herbalist-led integrated medicine practice in Ghana Health Service, the story so far. The presentation outlined most of the information has been given with the introduction, and therefore I'll skip the introduction and move straight to the scope of practice and function of the medical herbalist within an integrated center. We'll look at top 10 diseases within the period that we have served. Then we'll also look at, because of time, we'll look at 2 case clinical presentations where herbal medicines were used. Source of our medication, achievement, and innovations. Then we'll look at few challenges. Then benefits of the integration when it is fully implemented. Then expectation from our stakeholders. Then we conclude. So with the introduction, much has already been said by Prof. And therefore, I will skip those ones. The development has also been talked about, but what I want to emphasize is between 2011 and 2012, the Ministry of Health in collaboration with Ghana Health Service selected 19 public hospitals throughout the country to start with the implementation of the policy in a pilot basis. With this one, we had a stakeholder meeting in Koforidua in 2012. By that time, we had already practiced for a year. So I was even made to do a presentation for the year, how far we've come. And with that stakeholder engagement, Ghana Health Service, delegation from Ghana Health Service, Ministry of Health, Ambulance Service, National Health Insurance, academia, KNUST, University of Ghana, everybody was there. Then the director there, then Mr. Ahin gave a presentation and told us that we are going to do the pilot for 3 years. Then after the 3 years, it's going to be evaluated, then the gaps met, then it will be handed over to Ghana Health Service for full implementation, where we are going to use the essential herbal medicine list. And because of that, we were given medications as a starter, which subsequently we were supposed to dwell on and move on with it. In 2021, the integrated hospitals were scaled up to 55. However, currently, we cannot say that it is still 55 because we know that within the service we have the high staff attrition level, where some of the staff are leaving the country, and the medical herbalist is also part of it. Then the inability of the ministry to employ regularly, it has affected some of the integrated hospitals, and we are saying that without a medical herbalist within an integrated facility, there is no integration. Because the integration is based on the medical herbalist being at post and managing patients with herbal medicine within that particular sector. So if they are not there, it means that there is no integration. These are some of the selected 19 facilities, and you can see that it is scattered all over. When I started at Kumasi South Hospital, we were working in consulting room 4. We lobbied to get this particular clinic. We had a BUSAC fund that helped us with advocacy. And through that, we wrote letters to some of the companies, and they helped us to get this particular. And you can see that we have, within the services that the Ghana Health Service, the Kumasi South Hospital render, herbal medicine is bold. It means that they recognize what we do. Integrated medicine is a science which combines conventional Western medicine and any of the traditional medicines. Ghana, we are fortunate we selected herbal medicine. If you go to China, traditional Chinese medicine, acupuncture are being integrated. You go to India, Ayurvedic medicine is being integrated into the mainstream healthcare. Ghana, we are doing that. At the hospital, we are there. The focus is the patient. It's a patient-centered program. What will help the patient? A patient comes to the hospital with a problem. Are we solving the problem? How the patient get well is our priority. If the patient is supposed to use herbal medicine to get well, or the health improves, that is it. If it's allopathic medicine, why not? So it is not about integration. It's not about competition that people perceive, that we are there to compete. We are not there to compete. Who are we to compete? Who are we? The mainstay of the structure is the allopathic medicine. And we are there to patch and deliver for the patient. We are not competing. But for us to be accepted, acceptability and recognized, there is something in the herbal medicine. And therefore, if there is a need for a patient to take it and be well, why not? We are there to collaborate. We are there to complement, all with one aim, to make sure that the health of that particular individual has improved. The scope of practice and function of the medical herbalist at an integrated center. When a patient comes to the hospital, the patient goes straight to the records department. At the records department, the demographics are taken, and the patient is asked, which of the health practices do you want to be seeing? The patient will say, allopathic medicine, then they direct the patient there. Herbal medicine, they direct the patient to the herbal clinic. Then the vitals of the patient will be taken, then sent to the consulting room. You see that at the consulting room, the medical herbalist will be there with the patient and a nurse. The medical herbalist will take the history of the patient, then examine appropriately, come out with a provisional diagnosis and possible differential diagnosis. Then you expect that the patient will go and have investigations, either lab investigation or X-ray or ultrasound. Then the results comes for you to have your final diagnosis. That is where the beauty of the integration is. The final diagnosis is established, and you, the practitioner, will decide whether you can manage that particular condition. If you can manage that condition, first, if you cannot manage that condition because probably you don't have the medication, or probably a deficit in skill, referral is part of medicine. You have to refer to the appropriate specialty. And at our end, we have all the specialists within all the departments. And therefore, you call them, then you direct the patient to the specialist to man. However, when the patient wants when you can manage the condition, the medicines are cash and carry. So the patient goes to the pharmacy, then the medicines are assessed, the patient pay and come for the medicines. Then with first-time patients, what we do is that we call them on the second day to find out whether, apart from the medications that they take from the pharmacy, they bring it back for us to also counsel them the need for them to take. Some of the medicines are a bit bitter. Some of them are not. So you have to counsel them how the taste is, so that they will enjoy the taste. Then also, apart from the medication, non-pharmacological interventions are also very important. Lifestyle changes. If the social history tells you that the patient is alcoholic or smokes, you have to counsel the patient. If the BMI is high, you have to ask the patient, to exercise and also change the diet. So we do all that. And if you come to the pharmacy, you can see that the medicines are in the cabinet. We have the stock, bulk of the medicines are at the pharmacy stores, and requisitions are used to bring them to the pharmacy. Full patient documentations are achieved there, and therefore it enhances research. However, with the abrogation of the LIMS, light wave information system, we've lost a lot of data, not only with us, the Herbal, but it cuts across all the divide, within Ghana Health Service. However, we've heard that the CHAC, the Christian hospitals are being allowed to still use the LIMS, and they have their data intact. We participate in all hospital activities. Currently, we are having peer review at our hospital. I'm the chairman for the committee, and I am here because I love Herbal Medicine Department. Thank you very much. We also do health education in the public. We go to the churches, markets, place, lorry stations, information centers to advise patients on the use and misuse of herbal medicines. The attitude of the informal sector is such that they hardly come to the hospital, to the extent that even if you are close to them, for them to come and screen, they will not come. You have to beg them. For them to get out from their stalls and come is a problem. So anybody at all will have a bag in front, just hanged around them. They move around. They will mention 5 disease conditions. If your head is still still, they will mention another 5. You definitely fall into one. Then they will give you medication. So we try to tell them that it's not worth. And we also go to the information centers, and it is very bad, very bad. And you see, before, some of us, we go there, we don't pay. We are Abai Nipa. We go there to educate the public. And therefore, we don't pay. But those who pay, after they have left and you get the microphone, you have to do a lot of damage control because they have polluted the system. And there are queue of people going to buy their medicines. You ask them, are you registered as a practitioner? No. Are your medicines registered? No. I want to work small so that I can get money to go and register. But why not go and register yourself? And most of them are not the real indigenous practitioners that we know, who, per their experience, we are what we are now. You see, these are quacks that needs to be taken out of the system. We are member of the procurement team that deals with only herbal medicines. Even with that, the pharmacists, honestly, they are not helping us. We are in the same faculty. But we have the essential herbal medicine list. They will tell you what they know is Center for Plant Medicine Research. And if we go to Mampong and we don't get some of the medications, it makes prescription very, very difficult to man a particular disease condition. They will not buy any other apart from, because they don't have the policy to tell you that the essential herbal medicine lists are there for them to procure for you. So some of the because of time, no, let me do this one. Oh, sorry, let me do this one. Over the years, let me skip this one. Good. We have the 10 disease conditions, malaria, urinary tract infections. However, recurrent urinary tract infections are referred to the urologist. Neuropathies, peripheral neuropathies, alcoholic neuropathies, drug-induced neuropathies are being manned over there. Gastritis, enteric fever, peptic ulcer disease, hemorrhoid, diabetes mellitus, mild, uncontrolled, are referred to the allopathic sect, and also hypertension, with mild hypertension. There are cases that are referred to the Herbal clinic. Chronic arthritis, hemorrhoids, even third-degree hemorrhoids are being manned. Previously, we normally refer until a patient decided that I am not going under the knife. Hemorrhoidectomy, I'm not doing. I'll go to other places to find out whether I can get help. So we decided that no, we manage first and second degree. Why not, if this guy is saying that no matter what, he's not taking the go under the knife, why? Let's start something. Then we started, and we were able to help this particular patient. So we do well with hemorrhoids, benign prostatic enlargement, Euro 500 from the Center for Plant Medicine Research, hepatitis B infection, recurrent enteric fever, chronic asthma, acute asthma are normally sent to the ER. Musculoskeletal pain, peptic ulcer disease, erectile dysfunction. We have a medicine for that, erectile dysfunction. Then non-specific cough are also cases that we also refer to the Orthodox clinic. Early sizes, that is pregnancy. The patient will come with fertility issue. We manage, we refer to the ANC. Appendicitis, incomplete abortion, and most of them are surgical inclined. Diabetic foot gangrene, we refer to Dr. Boatin at Kokufu. He does very well with that one. We are doing two case presentations. A 46-year-old patient one, a 46-year-old male teacher by name presented with headache, body body weakness, loss of appetite for a period of a week. He had cough, but unproductive one. Had fever, bitter taste in the mouth, easy fatigability. There was no chest pain, no chills, no insomnia, no palpitation, no dizziness. With medical history, he had no peptic ulcer, sickle cell disease, or the chronic diseases, and he had also not done any surgeries. Drug history, acetaminophen had been taken 3 weeks prior to his coming. Ciprofloxacin, paracetamol B complex, had no known allergies. Social history is married with 4 children, stays in a 3-bedroom flat. He takes alcohol, he said, in moderation. But he does not smoke. On examination, a middle-aged man, febrile, mild pallor, anecteric, well-hydrated, an impression of malaria, ruling out enteric fever. Then because of the pallor, mild anemia. The plan was to do blood film for malaria parasites, full blood count, and blood culture to rule out the enteric fever. The lab results shows that blood film for malaria parasite, 2,690 parasite per microliter. The full blood counts were unremarkable, except the HB, which was 11.3 grams per deciliter. There was no bacterial growth. Herbal treatment given lepiquin, herbal mixture, and tonica from the Center for Plant Medicine Research. Non-pharmacological intervention to take more contumely and solanum tovium, stop alcohol, exercise regularly because the BMI was within the obesity range, add any of the citrus fruits, it can be whichever he wants. It can be citrus sinensis, arantifolia, lemon or tangerina, any of them, they can take that one. On review, on the 8th day, the patient health has improved, but still feels slight headache. The BP was normal, and the temperature had also come to normal. The lab results, MP shows no MP seen, and hemoglobin had improved to 12.2 grams per deciliter. The review followed up by phone. On the 14th day, the patient health has been restored. All the symptoms presented have been improved. We have an alternative. However, to say this, an observation with some of the herbal anti-malarias, with parastemia levels more than 3,000 parasites per microliter, some of them, after 7 days, you find a residual parasite that needs another anti-malaria herbal medicine to clear them. Some of them, for beyond 4,000, you still have a residual parastemia. Only one that we have observed that above 5,000. So you need to do blood film for malaria parasite before you can give the anti-malaria. The second patient is a 36-year-old male banker named ZZ, presented with anal pain, blood in stool, lump at the anal region. It had lasted for 2 years, on and off, when the patient is on medication. History of presenting complaint: the patient was well until 2 years ago when he started experiencing pain in the anal region with intermittent bleeding and pruritus around the perianal region, especially when he sits for long. Because he's a banker, he sits for long. The onset of the pain was gradual and dull in character with no radiation. It aggravates when he strains during bowel movement. And most at times they are also constipated. While he gets relieved when he moves around or sits on a warm bath. A lump started developing at the anal region, which began to increase in size until he decided to send it to the hospital for treatment. He was given medications, and it normally improves with the treatment. However, there is a relapse. It's reoccur, and when the medicines are finished, therefore he decided to come to the hospital to seek herbal medicines. On direct question, there was anal itching, dizziness, There was inner itching, dizziness, constipation, loss of weight, change in bowel habits, but there was no insomnia and loss of appetite. He had no surgeries, but had been diagnosed of peptic ulcer, and it has been resolved. Drug history, suppository anosol, suppository Sherrypoct, tablet amoxiclav, tab diclofenac, tab ibuprofen, then other herbal medicine that he has taken. Social history, he's married with 2 children, sits for long hours at the workplace, habit of straining during bowel movement. He takes alcohol, he says, in moderation, but he doesn't smoke. On examination, a middle-aged man who cannot sit, throughout the history, the guy was standing. Sits more, no. And looked worried, has permanently prolapsed out the inner canal and cannot be manually reduced. And when it happens, when it cannot be reduced by pressure, it means that it's getting to the 4th degree hemorrhoid. So an impression of 4th degree hemorrhoid was queried, and the plan was to do blood film for full blood count, blood culture, protosigmoidoscopy to identify the degree of or the stage of the hemorrhoid. The lab results shows that full blood count was normal or unremarkable, except the HB, which was 9.9 grams per deciliter because of the bleeding. Blood culture, no bacterial growth. Protosigmoidoscopy report indicates 3rd degree hemorrhoid. Despite the fact that we thought it was 4th degree, but I said 3rd degree hemorrhoid with coexisting mild non-thrombosed external hemorrhoids. Treatment given, PAL mixture from Center for Plant Medicine, Kantinka BA, Kantinka Herbatis. Even the name kills germs. Tonica, PAL mixture, PAL ointment from Center for Plant Medicine. We also asked the patient to eat more contumely and solanum because of, though we have given tonica, but we still had to advise on that one. To stop alcohol, exercise regularly, avoid straining, limit time on the toilet to less than 5 minutes, then increase dietary fiber, increase fluid intake. Take avocado pear, 1 every day, one every other day, or take apple every other day to help with the management. The guy was supposed to come on a month time, but the patient came on the 6th week. The symptom presented had improved, still experienced moderate pain when he sits down. This time the patient sat partially with one part of the bottles. The rector on examination by almost 1/3 of the size, remaining 2/3. The patient was asked to continue the treatment and come for a review on the 6 weeks time. The patient came on the 20th week. The patient sat comfortably. I said, "Is that you?" He said, "Yes, it's me." "Are you sitting?" "Yes, I'm sitting." The prolap has reduced considerably to about 1/10 of the size that they presented. And he was asked to continue. With this, we ran the chemistries, and all the results were unremarkable. Very, very wonderful. So we asked him to continue with the treatment. The patient decided not to come again. We called, and he said he's working. He feel whenever there is any other prolapse, he will come back. Otherwise, he's comfortable. We have an alternative. We don't have it all, but we have an alternative. And therefore, when a patient comes to or a patient wants to opt for herbal medicine, let's give them a chance. Why not? We may manage it. Our source of herbal medicines, initially we had the medicines from the Center for Plant Medicine from TAMD, and it covers all the medicines in the essential herbal medicine list. Subsequently, as I said earlier, they decided not to buy it for us, only Center for Plant Medicine Research. And we convinced, we are part of Drug and Therapeutic Committee, but no matter what you see, the pharmacists had the say. And it's like they are buying the medicines for you. I won't go there. So these are some of the criteria that key achievements. We visit churches, Lorry Parks, I've said it. We design posters with adequate herbal medicine information and post it in critical areas. We supervise herbal medicine students. Some are here, very beautifully dressed. We serve as consultants to the indigenous practitioners within our periphery, within our community. They come with the labs, they call us, they've done this and that, and it's good because we are bridging the gap between some orthodox practitioners and the medical herbalists. When we are at the clinical meeting and we are presenting, some of them will be making, so these are easy. But gradually, those whom we work together, they will always refer. They will ask whether we have an alternative. If we tell them yes, they will refer and come. We involve them in case presentations. We give feedbacks on follow-ups. Then we also take part in all activities. Key challenges: limited options because of the way the pharmacists have structured the thing. We have limited options. It is only the medicines that we have at the Center for Plant Medicine Research. Otherwise, we don't have anything. The costs are strictly cash and carry. And so it means that if you don't have money, you can't come on review. Lack of knowledge. A lot of people, even when they see the clinic, they think that it's a private thing. We tell them it's not private. All of us, we are being paid by the government. This is a bindia. Lack of logistics for follow-up. I said that we call patients, the first-time patients, and at times we will not get the logistics. However, we are managing. National health insurance do not cover the medicine part, and therefore, that is how our patients are suffering. 95% of our patients are national health insurance card-bearing members. So it means that we are not treating them well at all. There are no space for some of the practitioners. Some of them, they have to come in the afternoon, and some of them, they have to patch other people within the consulting rooms. Shortage of herbal medicines. When there is a shortage at the center due to inability of some of the plants, then it means that it affects the integrity of the management. Unserved prescriptions cannot easily be, you can't get it within the pharmacies, because of the medicines that we use. Strategies that we use to address some of the challenges: we hang banners to create awareness. Patients are assured that very soon, from 2012, we assure them, very soon, NHI may include the medicine. NHI may include the medicine, and they are not including. Quarterly orders of herbal medicines are made. However, at times it will be 6 months. Meanwhile, we are off behind the buffer level, which needs restocking. However, they will not. Payment methods: clients are made to pay what they can afford at any point in time until uninterrupted treatment is over. And that also helps us. You take this, you go, then when it's about finishing, you hurriedly come over and take some. We've had a lot of visitors around the globe, and they come with different reasons. Some from South Africa and all that. Some come to inquire about the integration. Some come for research purposes. And we've had about 5 delegates from Nigeria. One particular one, they wanted to assess the level of tolerance among the health professionals. After we have introduced the medicine, they gone to the pharmacy to introduce them to the medicines, they went to the OPD. We should lead them to the OPD. We went to the OPD, they were interviewing the nurses. How far? How are you coping? Like we are devils. How are you coping with them? Are they harming you? They are saying it will be very difficult for Nigeria to establish such an integration. It will never happen in their country because the way their style, entrenched style that you just can't maneuver and come and implement this there. The allopathic medical doctors will hang you. So we are lucky. Ghana, we are blessed. Benefit of the integration when it's fully implemented. There are a lot of benefits. Early detection and referral of diseases. The patient come. If we cannot manage, we refer immediately. And it is a plus thing. We improve documentation and therefore it's reliable. Better pharmacovigilance. We call them to find out whether there is any adverse reaction that they are going on, so that immediately they will stop taking the medicines. They come over, we do the documentation, it's sent to the FDA for pharmacovigilance. High demand for quality of service and standards, because we use that as a standard, as a yardstick. And it will definitely reduce quackery. Public education will also make the client more informed and better protected. And as Prof said, there are a lot of economic benefits, a lot of them. It will reduce drug importation bill. If it's within the insurance scheme and everybody is coming, definitely the rate at which the cultivators, will cultivate demand medicinal plants will be high. It will create a lot of jobs for cultivators, collectors, transporters, manufacturers, packaging, distributors, wholesalers, retailers. It's very long. All the chain of production, there will be jobs around. Possibility of exports are also there. There are a few drawbacks. Though it happens outside the integrated centers, but it affects us. Just last month, a surgeon came to our place and he said, Ebo, but you guys, we thought that if you come, after you have come, things will change. We haven't seen any change. You and your people. I said, which people? You and your people. I said, the people is for all of us. So those ones affect us, and therefore we have to do something about it. Expectation from stakeholders, a few of them, the government should give tax incentive to the local herbal manufacturers to bring down cost of herbal medicine production. Gone are the days where we say herbal medicines are cheap, accessible. Herbal medicines are not cheap again. When patients are assessed and they are going to pay for the cost of their medicines, you can see sweat. It's not cheap. Moreover, when he goes to the allopathic medicine, it's free. But we ask them to pay. And we have to pray for our patients. Save solid dosage forms. Most of the medicines that we have are liquid dosage forms. And you can imagine, somebody you've given 3 months period medicines, decoctions, and they are traveling from one end to the other, 42 kilometers. You can imagine the sound. We need stable, solid. It is with you, and nobody will even know that you are holding a medicine. Funding agencies, as Prof said, we need them. If we are able to get even 5% of the funds that they allot to allopathic medicine, we are better off. They should help us with that. Center for Plant Medicine, we also say they should get a depot and to serve the Northern Part. And medical herbalists should think of rebranding. We don't have a name. You come to Ghana Health Service, it's physician assistant herbal, into bracket. They decided to change it for a long time. They haven't changed it. We don't have an identity. If you go anywhere, if you want any interpretation of medicine, consult the pharmacist. Consult the pharmacist. We don't have a name. So we have to think of rebranding so that at least it will serve the purpose. In conclusion, the integration of herbal medicine into the mainstream healthcare in the country has come to stay. Its acceptance by the stakeholders is critical to the success of the policy. Proper collaboration between the practitioners will reduce the negative perception that we have with herbal medicine. Practitioners of both healthcare see the integration as a patient-centered. When the patient needs, which have to give it to them, and not to show prowess or discrimination against one another. We've done a lot of research on surveys on some of, and more than 95% of clientele will not disclose their herbal medicine intake. They will tell you, I don't take it. Meanwhile, they take it. And they will give you all sorts of reasons why they are not disclosing the herbal medicine that they have taken, all because they will be shortchanged. Take the herbal medicine guy to the back, and he will be seen the last. Public sensitization is key. Then integration of herbal medicine in Ghana has come a long way, and through the effort of all the stakeholders. Nelson Mandela once said, "It always seems impossible until it is done." These are people we are acknowledging, and these are some of the references. Thank you very much. I'm very grateful.
Thank you very much, Dr. Tete, affectionately called Uncle Ebu. Shall we please put our hands together for him again? That was a very comprehensive overview on how the integration is faring. We were joined by the Dean of the Faculty of Pharmacy and Pharmaceuticals, Natural Products, Kwesi Christian Herbal Clinic, Entry Herbal and Spiritual Center, V2 Herbal Care Clinic, Solak Biochemist Limited, Kwa Research and Manufacturing Company Limited, Kasum Abango, 777 Herbal Center, SO Herbals, Joy Industries Limited, Health Alert Clinic, Amuzu Manufacturing Limited Company, and Piwak Natural Health. Having thanked our sponsors, I would like to invite Professor Fred Stephen Safo for the closing remarks. Please, let's welcome him.
Thank you very much, Prof. Kwetia. I think we need to give a round of applause for our MC. She's emceed this program so elegantly. Well done. I also want to thank our deans for coming to support us in this program. We are so grateful to you, deans. I see 3 deans here, very powerfully representing our college. Thank you very much. When the provost asked me to represent him this morning, I accepted it gladly because I told myself I'm coming here to learn. I'm always a student, so I brought my sheets of paper. I've taken a lot of notes. I think we've had a captivating plenary session, and a round of applause for our speakers. Professor Regina Appiah-Oppong set us off with a presentation on harnessing Africa's medicinal plants for herbal and economic development. And she said that even though 80% of our people are using herbal medicine, there's a question that we need to ask ourselves. The fact that we are using it doesn't mean that they are safe. Doesn't mean that we are using them at the therapeutic doses. One of the comments, I belong to the allopathic side, so one of the comments that we've heard is that, I don't know, meat and naho. So they just tell you drink. Okay, but I'm reorganizing myself. I've come to learn a lot. So when I go back to my people, I'll tell them it's not true. There's meter on it. She also asked us about the scientific basis, and she actually provided some captivating data on the efficacy and safety of these products. She looked at AM1 for malaria. She looked at Absigia ziga. I asked her for the pronunciation. Have I got it right? Albizia ziga, yes, which had excellent anti-cancer properties for leukemia, for prostate, but not for breast cancer. And then I also learned about morinda for trypanosomiasis and leishmaniasis. You did some excellent work also on the cytochrome P450, something Prof. Ansan was talking about when I was a medical student. You taught us pharmacology. Cytochrome P450. so, so there's some work ongoing over there. I think she warned us about the dangers and the challenges ahead, mislabeling, misidentification, adulteration of herbal products, and ended on the herbal, the economic value that we stand to benefit from tapping into the herbal medicine industry. Then we had a scholarly presentation from Professor Monticello, my own friend Mo, and he spoke about transforming local herbal knowledge into global health and focused on Cryptolepis sanguinolenta, which had excellent antiviral properties, and shared stories on hepatitis B and how efficacious it was. And also Eckhart, which has worked for a professor that he knows, and he's probably taking some himself. Okay, so I'll come and see you so that we see. I have a lot of patients with osteoarthritis. I'll give them diclofenac, it's not working. So I'll come and see you so that we see the way forward. But his famous quote was that we shall become rich if we tap into the money that is potentially available for us. And then concluding was an engaging presentation by Dr. Andrew Stete, who herbalist integrated medicine practice, and he shared success stories from the Kumasi South Hospital, looking at integration as not a competition, but rather a recognition and acceptability, collaboration and complementarity. And the quote I'm taking from him is that we have an alternative, and at Ghana, we are indeed blessed. So what is the clarion call for us, for all of us? Well, there are four of them. One, that herbal medicine is nature's pharmacy. Number two, there's a need to merge local knowledge with scientific rigor of evidence generation to ensure that our products are safe and efficacious. Number three, as an institution, we should be minded that Plan 2K35 pushes investments into herbal medicine. And in my presentation, I said I'm not a prophet, but I foresee the herbal medicine growing into a faculty or even a school going ahead. And those are areas that I believe we should push hard so that we can grow our college. And number four, as a nation, we need to make bold investments into herbal medicine so that we can tap into the $70 billion market that we've been exposed to this morning. On this note, we'd like to thank you all very much for your attention. Let's make sure we join the abstract presentation, poster presentation, so that we get ourselves familiarized with more of the data available. Thank you very much.
Thank you very much, Professor Safo. Please let's make ear for these announcements. After we have left here, there will be a photography session on the ground floor at the foyer where the poster boards have been set up. Just beneath or at the staircase, we will have some photography, and that will be for the dignitaries, speakers, with the provosts, deans, HODs, and invited guests. I think all those who will be in the photography know themselves, and I'll also be part. Again, we'll be having the parallel sessions. This room, the Gardiner Conference Room, is parallel session A. This is where we'll be having parallel session A. And then on the next floor down, where the OGR is, we will be having the parallel session B at the OGR Conference Room. Please take note that there will be some non-pharmacological interventions, as Uncle Obo told us. So we'll be having some snacks. This one is not contumely and solanum. It's going to be, you know, some snacks, drinks, and then we'll have the heavier non-pharmacological intervention after the oral and the oral presentations or the parallel session. That will be the lunch. So I think those are the announcements. There's going to be evaluation of the presentations, both oral and poster. So we want our presenters to give out their best, and we ask that if you are going around or partaking, please engage actively so that together we can strengthen the herbal medicine industry and training. Again, those who are going to win for the best poster and oral presentations will receive a call, because we will not converge here after lunch. After the we will close in our parallel session rooms, so we will not come together here as in for a closing ceremony. But if you get, if you are going to win for the best presentation, you'll be called. Then you will join the closing dinner tomorrow. You'll be called and you'll be given the details, and then you can take your award at the closing dinner. So from here, we'll be having a snack break and poster viewing session on the ground floor foyer. Please let's invite Professor Isaac Ayensu to give us a prayer.
Shall we be on our feet and pray? Our dear Lord and Master, we want to thank you today. We thank you for the grace that brought us here. We thank you for all the talks that we've had today. We pray in the name of Jesus that continuing from here, you will guide us by your strength. Keep us and strengthen us throughout the day. And tomorrow, when we meet for the other portions of the work, it shall be to your glory. Thank you in Jesus' name. Amen.
Please, we have information that will a photo of this